Nursing Care During Labor, Birth, and Afterbirth, Chapter 16. Giving birth is a very special experience for women and her support person. Your job as a nurse is to help this be a good experience with good outcomes. The provider spends very minimal time with the patient during labor, so you basically are her go-to person. You are her and the baby advocate. You must develop a therapeutic relationship with them to help this happen. You must assess if they understand English, and if not, arrange for an interpreter. You also need to determine their expectations. We talked earlier about birth plans, so if they have one, most of their expectations should be there. Letting the family know that sometimes changes need to be made and your number one priority is for a safe delivery. You want to be sure that you are confident so you feel they can trust you. Be sure to respect cultural values and only use touch if it's appropriate for your patient. When a patient comes to the OB unit, a focused assessment needs to be done to determine her status. This will include looking at the prenatal record if it's available and verifying her gestational age, which is her due date, and determine any pregnancy complications. You'll place the fetal monitor on to obtain the fetal heart rate and any uterine contractions. Asking mom about if baby has been moving, any vaginal bleeding, or any other concerns. Asking if she has any leaking of vaginal fluid, as this can indicate a rupture of membrane, meaning her water broke. If yes, you want to know approximately what time this occurred, approximately the amount, color, and if any odor. You will ask if she has had contractions, and if so, how often, and if she's having any other pain. These are all important things to assess right away so you can determine if delivery is close. You also want to know her GBS status. GBS is group beta streptococcus. This is that normal bacteria women have in their bodies, but during pregnancy it can become in larger amounts, which can put baby at risk for contracting GBS. This normal bacteria is found in the vaginal and rectal areas. At about 35 weeks, the doctors will do a vaginal rectal swab that will test for that GBS. If it's positive, the woman will receive IV antibiotics during labor to decrease the risk of the infant contracting this during delivery. GBS can be fatal to a newborn. The use of antibiotics of mom dramatically decreases the chance the infant getting this. Depending on if you think she's going to deliver soon, it may be appropriate to do a vaginal check on her at this time to determine dilatation, effacement, and station. If she has vaginal bleeding, you will notify the provider and they would do the vaginal check. You will check mom's vital signs. Sometimes a woman can enter the OB unit with impending birth. She's ready to deliver. You still must place the fetal monitor on, and you would do a vaginal check to determine how close birth is and notify the provider. The rest of the assessment information will be gathered as needed and time allowed. Once the focus assessment has been completed, a more thorough assessment needs to be completed. You should have obtained why she was there and asked the questions we discussed in the last slide, but if you missed any of those areas, you should do that now. You would need to ask about past medical, surgical history, allergies, medications, complications with previous pregnancies, if she has a birth plan, use of alcohol, drugs, nicotine, if she has a support person, and you would screen for domestic abuse. Basically the same type of things you would do on any patient. You will continue with the fetal assessment by keeping her on the fetal monitoring, noting any abnormalities. We will learn how to read the monitor strips next week. You will also note her contraction pattern if she's having them and how she is tolerating them at this point. If a vaginal check has not been done to check for dilatation, effacement, and station, this will be done by the nurse or the provider. Then a regular physical assessment would be completed. If birth is not imminent, you typically will get a 20-minute fetal monitor strip on the infant before contracting the provider unless you see something abnormal. When you contact the provider, you will give them an SBAR, which will include the information you obtained during your assessment. If she is being admitted for labor, typically labs will be drawn at this point. They will usually do a type and screen, so if she needs blood, that would be done. They will do a CBC and sometimes a UA. If any of her prenatal labs were not obtained, they may need to draw further labs. Most patients will have an IV or saline lock while in labor. If she's planning on using any type of medications for pain relief during labor, she will need to have at least a saline lock. Many times they do not need to have fluids running all the time, but they want access if needed. There's nothing worse than having a patient crash and not have IV access. If mom was GBS positive, like we just talked about, she will have to have that IV so she can receive antibiotics. Penicillin G is a drug of choice, but there are other options if she has a penicillin allergy. If she's going to have an epidural, she will receive a 1,000 ml bolus of IV fluids prior to getting it. One of the side effects of epidural is maternal hypotension, so by giving the bolus prior, that helps decrease the chance of having hypotension. Continuous assessments continue while the woman's in labor. How often these assessments need to occur varies on the stage of labor she's in, any complications, or if she's receiving medications to induce her labor. Maternal assessments include her vitals, contraction patterns, progress of labor, is she dilating, her intake and output, remember we need to empty her bladder to make sure there's room for the baby, and how is she responding to labor. This includes her pain assessment. Is she using non-pharmacological measures, or is she receiving pain meds? The fetal assessment will include that fetal heart rate and any abnormalities and the amniotic fluid. If her water has broke, we assess for color. Typically, the amniotic fluid is pale yellow and could have some vernix present. Sometimes the infant can have a bowel movement in uterus. The first bowel movements in the infant that the infant has is called meconium. Remember, meconium is that thick, tarry, greenish, blackish in color. If they have a stool in utero, it will turn the amniotic fluid a light brown to green color. Meconium fluid can cause problems for the infant if they swallow that fluid during labor or birth. They can have meconium aspiration pneumonia from it. As nurses, we want to know the color of the fluid so we can anticipate if the infant's going to have problems. We'll talk more about what we do for the infants in the upcoming weeks. Women will continue to leak fluid most of their labor. The bed will be lined with blue chuck pads, so an important nursing intervention will be to change those pads as they become wet. This is for her comfort, but also to reduce the risk of infection. We will assess how the support person is doing. Are they being helpful to mom? We can't make them be helpful, but many times they do not know what to do, so providing them with things they can do will help. Getting mom more fluids to drink, offering to rub her back if she wants, or just being supportive and telling her she's doing a good job. Throughout your book, you will find purple boxes that are nursing care for the topics we are talking about. These are good because they go over some assessment data, nursing diagnosis, and planning and interventions. I highly recommend you look at these boxes each week, as this helps pull all those pieces together, and I'm sure you'll find some test questions come from these boxes. In false or early labor, you assess the patient to determine if her labor is progressing. Remember, to be true labor, she has to make those cervical changes. Many times when they come to the hospital, they don't know if it's true labor or not, so the biggest concern we have is knowledge deficit. We will provide reassurance and listen to her concerns, but we'll also educate on when to come back to the hospital. We'll teach signs that labor is progressing. For a woman in true labor, the nursing diagnosis or concerns are geared towards her needs. Anxiety or pain could be her biggest concern. We'll educate on things to expect, teach coping or breathing techniques, answer questions, and provide support. Discomfort or pain is another area of concern if she's in labor. Remember that anxiety can heighten pain, so using a calming approach, keep the patient and family updated, and being supportive can help. You must determine what her plans are for pain control. We'll discuss pain medications more in depth in another week or so now we'll just focus a little more on the non-pharmacological measures. One is providing a calm environment. We do this by keeping the lights low, finding calming music, keeping the temperature to her liking, are all things. We will provide comfort as far as keeping her clean and changing her blue chucks as needed. Offering things for her like oral care since she may not be eating much, reminding her to empty her bladder can decrease her discomfort. Finding comfortable positions for her as well. Encourage ambulation in the room or hall if she doesn't have restrictions can help. The use of the birthing ball or sitting in a chair. Using a form of distraction such as guided imagery exercises for mild discomfort can help. Being very supportive and giving positive reinforcement so she doesn't become discouraged is helpful as well. One of our other concerns is prevention of injury for both mom and fetus. As for mom, we want to keep her safe by making sure she's ambulating. If she's ambulating, she's steady on her feet and not using pain medication that puts her at risk for falls. If using an epidural or an intrathecal for pain, she is at risk for injury for both of these. Sometimes, if she's using an epidural intrathecal for pain, she's at risk for injury for both of these because she'll have decreased sensation to her lower extremities, so being sure she's not ambulating at that time. When it comes time to pushing, make sure she is, make sure that she's in a good position and someone has helped to guide her legs and to hold her legs. Sometimes they'll take the bottom part of the bed off and they have stirrups for her to put her legs in, and sometimes needs to be sure that she has the help to get her legs in there to be safe. Making sure she is changing positions is something that we can do by watching the edge of the bed so she doesn't fall off. As far as preventing injury to the fetus, you will monitor the fetal heart rate to ensure proper oxygenation is occurring. So now it's finally time to have the baby. What are your responsibilities as a nurse? Of course, you can see some variety in these tasks from facility to facility and even provider to provider. Midwives are much more hands-on and may do some of the things that nurses would do for a doctor. One of the things that needs to be done is setting up the delivery table. Hopefully you will be able to see the nurse do this. Birth is considered to be a sterile procedure, so a sterile table is prepared. This is typically done once they know the patient is in labor and being admitted. There's nothing worse than the woman progressing very quickly and now you don't have time to set up your table. The table consists of sterile gowns, gloves, and the surgical instruments that may be needed to assist, sutures for any repair work, and other things. When it's close to delivery time, the patient's perineum is cleansed with a prep to decrease the risk of infection. Positioning the woman in a safe position and a comfortable position is something else you do. There's a drape that will be placed under mom, and this may be done by the provider. During the birth, you are supporting mom, monitoring the fetal heart rate, and doing anything the provider needs you to do. Occasionally, the provider does not make it in the room in time for delivery, and the nurse may have to deliver the baby. Most nurses are shown what needs to be done in this situation while she's training. When I trained in OB, our one provider had me deliver a couple babies with him in the room so I would feel comfortable if I ever had to do it. You would put your call light on to get extra help and extra nurses into the room. Once the infant comes out, the placenta will need to be delivered. There isn't much you are doing during this time except to help during this time to get the placenta out. You're supporting mom, getting the provider anything they need, and helping with baby if need be. A separate nurse should come in just before delivery, and the nurse is in charge of caring for the infant after birth. If the infant is having issues, you may have to help. After the placenta is out, almost all women will get oxytocin. Oxytocin or Pitocin is used many times to induce labor, but is also used after the delivery to help the uterus contract back down. If the uterus does not contract, it will be boggy and puts her at risk for postpartum hemorrhage. The provider will repair any tears or an episiotomy if it was needed once the placenta is out. Care of the infant right after birth includes making sure they have a patent airway and good respiratory status. We must be concerned with thermoregulation since infants have a hard time with this. The infant will be dried and either placed on mom's chest or will be taken to the radiant warmer in the room. Either way, wet blankets need to be removed from the infant so it does not cause cold stress. Sometimes the infant may have oral secretions, so suctioning may be necessary. They will identify the infant by placing 2 bands on the infant, one on the wrist and one on the ankle. This band has numbers on it that matches mom's numbers, and an additional band is given to one support person. Footprints on the infant will be obtained, vitals will be checked to ensure they are transitioning well, an APGAR score will be given to the infant. This is a score given to the infant at 1 minute and 5 minutes of life. These categories they are scoring the infant on. Each category gets a score of 0, 1, or 2, with 2 showing transitioning is going well. Table 16.3 outlines the categories that they're being assessed for that. Vitamin K and erythromycin will be given and Hep B if that consent was obtained. A photo will be taken and placed in the infant's record as a safety measure. One of the biggest concerns we have for mom after delivery is being sure she's not bleeding too much. We will assess this by monitoring her lochia. The pads may be weighed, and if not, the nurse would document if it's scant, small, moderate, or heavy amount. Fundal checks will be done routinely after delivery as well. Remember, we want that fundus to be firm. Boggy uterus puts her at risk for hemorrhage. We will be monitoring her vitals as well. Assessing her pain, if she had an episiotomy or laceration, we will assess that we will be looking for any signs of a hematoma or excessive swelling or bruising. Providing ice to the perineum should be initiated and offering the use of an NSAID as well for the inflammation. If she has not emptied her bladder recently, we would either assist her to the bathroom or provide a bedpan or straight cath. Many women will feel chilled after delivery and can even have the shakes. This is thought to be from hormonal changes, so providing her with a warm blanket can help. We also want to promote bonding. We will encourage her to feed the infant right away and get to know the infant.